Hello, I would like to welcome you all on today's talk about obstructive sleep apnea assessment in the elderly. My name is Renata Pecotić and I'm head of Department for Neuroscience and University of Split School of Medicine, and I also work in a Split Sleep Medicine Center. Obstructive sleep apnea is one of the most common sleep-related breathing disorders characterized by repetitive episodes of complete or partial obstruction of the upper airways, followed by significant oxygen desaturation while respiratory efforts still persist. Chronic intermittent hypoxia is one of the main consequences, and combined with the frequent arousals during sleep, results with dysfunction of autonomic nervous system and promotes further development of chronic diseases such as hypertension, glucose intolerance, cardiovascular and cerebrovascular disorder. We might say that obstructive sleep apnea increases with advancing age. What happens during the night is that because of the complete or partial obstruction of the upper airway, there is no airflow, oxygen desaturation happens, increase in systemic blood and arterial pulmonary pressure occurs, also increase in sympathetic nerve activity, and sleep fragmentation because of the microarousals or complete arousals in the EEG promotes pathophysiological mechanisms like oxidative stress, inflammation, endothelial dysfunction, and changes in circulating factors that promote development of different types of the chronic diseases. Prevalence of OSA has substantially increased over the last decades and is expected to increase furthermore due to increased prevalence of obesity and aging of the population. If we use a definition of 10 or more apneas and or hypopneas per hour of sleep, OSA prevalence estimated in older adults might be as high as 70% in men and 56% in women, which is in contrast to prevalence estimated in general adult population of 50% in men and 5% in women. However, it needs to be emphasized that it has been estimated that over 80% of patients with moderate to severe obstructive sleep apnea are still undiagnosed and therefore untreated. The percentage of low-risk subjects decreases with increasing age. Phenotype of OSA can look a little bit different in older adults compared to the young ones. And after the age of 60, the prevalence of OSA is equivalent in males and females, and obesity is no longer a significant risk factor, and witnessed apneas and snoring are not as frequently reported as it is in a younger group. Older adults are also more likely to present with more sleep-related complaints, including daytime sleepiness and nocturia. Why are older adults at risk for obstructive sleep apnea? Because with aging there is a loss of tissue elasticity as well as sarcopenic muscle wasting. With aging there are structural changes to the upper airway, including lengthening of the soft palate and upper airway fat pad deposition. Also, those changes increase the tendency of oropharyngeal region to collapse, and therefore ventilatory control instability may predispose older adults to apneic events while sleeping. What are the negative consequences of OSA in elderly? Excessive daytime sleepiness, decreased quality of life, neurocognitive impairment, nocturia, worsening of cardiovascular diseases, particularly arterial hypertension, heart failure, and stroke. Diabetes mellitus and depression have also been found to be more common in older adults with OSA, and although sleep disturbances are common with aging, it is not an inherent part of aging process, and we should take into the consideration other medical, psychiatric, and psychosocial factors that overshadow age as a risk factor. Sleep disturbance in older adults is associated with increased morbidity and mortality. Various strategies have been employed to easily screen for OSA. The evaluation and management of sleep disturbances in older adults is best approached as a multifactorial geriatric health condition arising from impairments in multiple domains. And we usually use the questionnaires such as STOP and STOP-BANG questionnaire, which are concise and easy to use in a daily clinical practice. And among the questionnaires, the STOP-BANG questionnaire has the high sensitivity, but the specificity is relatively poor. The question is whether we can use same questionnaires for a different clinical population of patients and different age groups in the general population worldwide. Here are what the STOP-BANG questionnaire abbreviation stands for. So we ask patients about the symptoms of snoring, tiredness, observed apneas, and increased blood pressure, and also increased body mass index age over years of 50, increased neck circumference, and male gender. And in the project that we performed in the southern Croatia as a part of Interreg IPA CBC sleep medicine project, where we analyzed the risk for obstructive sleep apnea using stock questionnaire in a general population of around 4,000 people, we found that the highest percentage of those who are at increased risk for obstructive sleep apnea are found in the age group of 70 years and over. And also, among the female subjects, majority of female subjects are having increased risk for obstructive sleep apnea in that age group, which is similarly represented here in those charts, where you can see that in a relatively younger group of people, male subjects do tend to have higher risk for obstructive sleep apnea compared to the female, whereas with increasing age, those things are changing. And we concluded that the risk for OSA is equalized in the population of men and women in the southern Croatia in a population above 61 years of age. The risk of OSA is slightly higher in the female population, and because of these reasons, we need to pay attention to timely screening of those who are at increased risk for OSA because of the negative effects of OSA on quality of life and increased morbidity, but also mortality from cardiovascular and metabolic diseases. Recent evidence suggests that the accuracy of obstructive sleep apnea screening instruments in elderly might be changed as the predictive role of gender, age, and body mass index changes with aging. And therefore, novel modification of a standard instrument created adaptive version of simpler to obtain and useful to exclude OSA. So screening seniors with the questionnaires to detect OSA might be a little bit problematic, and we should think or take into the consideration sensible option to indicate performing of objective tests such as oximetry or even polysomnography as the first step in OSA investigation in elderly. In conclusion, we may say that the evaluation and adaptation of screening methods for sleep disordered breathing in elderly is needed, that the diagnosis of OSA should be done accurately and made in timely manner in order to prevent all negative consequences of undiagnosed and untreated OSA, especially in a group of people who are already being diagnosed with chronic diseases such as arterial hypertension and diabetes. And only with a better sleep or better quality of sleep, we can achieve a better and healthy aging, which should become one of the priority nations worldwide. And at the end, I would like to thank you all for your attention.